And welcome to the Broadest Shoulders event. My name is Kelly Green, and on behalf of the Fabian Women's Network, I'd like to welcome you all this evening. We wanted to put on this event because with COVID-19 going through hospitals and in homes, women are absolutely on the front line. Women do the majority of the caregiving role within and outside the home, and are taking on most of the burden of caring for the sick and helping stop the spread of disease. So we really wanted to speak to some voices of people that are on the front line in the health service and elsewhere and hear their stories. So before I introduce you to our excellent panel this evening, I'd like to invite everyone who's presenting on our event to please use the hashtag FWN Frontline. And if you have any questions, if you can use the Q&A button, which should be at the bottom of your screen, then please put your questions in there and we'll come to some at the end. So I'll now go to our first panellist, who is the Right Honourable Jackie Smith. Jackie was a former teacher and went on to become the first ever female Home Secretary in the last Labour government. She's now chair of NHS Birmingham Trust, as well as the Joe Cox Foundation and Sandwell Children's Trust chairs. So Jackie, if you could tell us about your experiences and how you've been experiencing COVID on the front line.
Kelly, thank you very much indeed. Thanks for inviting me to take part in this event, and to Fabian Women's Network for focusing on it. I think it's extraordinarily important that we're able to talk about it. I suppose I feel like a bit of a fraud because it would be going some to say that I'm on the front line. You're right that I chair the largest NHS trust in England, but as the chair, I'm afraid I'm very far from the front line, but I'm very interested to hear what our other panellists have to say. So just as a bit of background, the trust that I chair, University Hospitals Birmingham NHS Trust, has 4 hospitals, a community service. We've had the highest, very sadly, we've had the highest number of cases and the highest number of deaths from COVID-19 in the country, including 4 of our staff who we miss very much. And we were responsible as well for building in a mere 9 days the Birmingham Nightingale Hospital. So because of that, I thought what I might do, and some of my previous experience, is focus a little bit on how I think that the frontline and national leadership has, particularly the national leadership, has demonstrated to us totally during the course of this crisis the significance of what many of us have argued for some time, and that is the need for diverse teams. Because when you don't have a diverse team, what you see is everybody suffering. So first of all, of course, we needed real visibility of women in decision making during the course of this crisis, and yet what we actually saw and see day by day nationally is a small clique of male ministers making the decisions. And of course, we've also seen what happens when you do that. I don't believe, had we not had to depend on Boris Johnson, Rishi Sunak, Michael Gove and Matt Hancock essentially making all of those decisions, that we would have seen some of the enormous mistakes that have been made as we've gone through this crisis. I don't think we would have seen the lockdown being lifted in such a way that very many women sat there on a Sunday evening thinking, how the hell am I going to get to go to work tomorrow, or even later on in this week, when nobody actually in that room has thought to ask the question, what about if you've got children to care for, or what about if the school that your children go to isn't open? And I don't think we would have made the economic impact so preeminent over, or the economic effects of lifting the lockdown so significant over the personal and the issues that the NHS and care are facing. Secondly, I think we've seen the need for empathy in leadership. So we've all, I think, admired the way that Jacinda Ardern in New Zealand has dealt with the political leadership of a issue like this. In my trust, certainly, the diverse team that we have in the leadership, and particularly the leadership of our chief nurse, Lisa Stally-Green, means that alongside dealing with the sort of numbers that I've talked about, alongside building the Nightingale, we've also emphasised things like how we ensure the well-being of our staff, how we recognise the loss and pain that people have felt, how we put in place the psychological support for people working on the front line, and some quite tangible things, like a local councillor contacted me to say, look, I represent quite a lot of Asian families, and the women who are in your hospital suffering with COVID, and of course, like many hospitals, we have a policy of no visitors except in very extreme circumstances, are unable to use some of the provision you've put in place for communication. Perhaps they're not so able to use the tablets and the other things that we'd brought in. So we were able actually to facilitate both special mobile phones and staff who were willing to spend time helping those women to communicate with their families. So I'm not saying that it's only women that can make these sorts of decisions about how you deal with an issue, but if we do not have teams that are diverse and that represent all the interests of people who are suffering and working through this crisis, then we most certainly won't make such good decisions. I think there's been a real challenge in terms of the way in which we collect data. We've worked quite hard in my trust to make sure that we are able to differentiate by ethnicity, by gender, the nature of people who are catching the disease and sadly who are dying from it. But that isn't something that we've always seen at a national level. And sometimes that data is actually being collected in a way that makes it impossible to differentiate the effects on different groups of people. Of course, there has been, and there are, because of the nature of the workforce in the NHS and in social care, a preponderance of women on the front line, which makes the failure to deliver appropriate protective personal equipment to people something that has disproportionately impacted on women. And it means that we've actually, I think, allowed people to suffer, even if not physically, certainly in terms of anxiety and the emotional impact on them, in a way that should never have been allowed to happen. We've tried in our trust to respond to that concern by having a process of individual risk assessments, even before that was proposed nationally, where we do try to evaluate the ethnicity, the age, the gender of people who are working. Are people pregnant? What changes do we need to make in order to support people who are working on the front line? And how can we make sure that managers understand the need to be responsive to those pressures? We always have tried at my trust, and it's been a particular interest of mine, just as one example, to also recognise the circumstances from which people may well be coming to us. So if we take the example of domestic abuse, we've tried and had a policy of having, relatively recently, but it's been really successful, of having independent domestic violence advisors in the hospital. This has been a time when all of us know that we've seen some horrific increases in domestic abuse, with people locked sometimes with the perpetrators of their abuse at home. We've seen some horrible examples in our trust, and we've had to work hard to try and maintain our focus on that during the course of this crisis. This week is Carers Week, of course, and I think the impact on the often women who are caring at home and now are having to do it without even some of the, even if inadequate support that they were previously receiving, is something that I'm sure has brought enormous pressure onto the carers, who take so much pressure actually off the NHS and social care every day of the week. And of course, we now know, not least because of some of the very good work that's been done, for example, by the Women's Budget Group and by Fawcett, that particularly Black, Asian and minority ethnic women will be disproportionately suffering the impact of both the lockdown and of the COVID crisis. They're more likely to be in debt. They're more they report having more difficulty in feeding their children. They're more likely to lose support if they're disabled or out of work. So out of this, we'll see the health inequalities that we came into this crisis with becoming even worse. And as lockdown eases, we know, or as we've been through lockdown, we know it's women who face the disproportionate pressure of providing childcare, of having the anxiety of how they respond, and who are more likely, I'm afraid, to suffer from the unemployment that appears to be coming down the track. My only hope, I suppose, from this is that as we have seen people willing to stand out on a Thursday night and clap for our carers and clap for the NHS, that we will recognise the ongoing challenge in years to come from COVID, because this is not something that is going to be out of our health system, and certainly the inequalities are not going to be solved anytime quickly, and that hopefully we'll see a response to this which prioritises not just spending on the NHS, but fair pay for those people who we've stood and clapped for on Thursday nights. And if it means that we finally get to grips as well with the social care crisis in this country and the disproportionate impact on the women who've worked in that sector, well, perhaps from a terrible tragedy, we may actually see some progress. So just in conclusion, thank you for organising this event. I think it is teaching us, and it will teach us a lot about how we lead and how we respond and how we tackle health inequalities. And I just only hope that we soon have a government that will be able to take that challenge on properly. Thank you, Kelly.
Thank you, Jackie. A lot for us to think about there, and I think you're so right about the lack of female voices in the government. It's so telling and so very clearly a terrible mistake. Can I remind everyone that's watching that you can ask questions on the Q&A button, and you can vote for your favourite question or what question you would like to support being asked all through the time that we're talking. So our next panellist is Dr. Sonia Adesara. She is a medical doctor and has worked on the front line all the way through this crisis. So I'm delighted that she's found time of her really, really busy schedule to join us tonight. So Sonia, over to you. Just need to unmute, Sonia.
I really hate Zoom. I was apologising for my dodgy Wi-Fi, and I should probably apologise for being a bit of a tech phobe. But thanks so much for having me. So I was texting Kelly yesterday asking what should I talk about, the experiences of the past few months, and I was thinking, God, where do I start? And to be honest, it's been pretty surreal. I think, you know, as a doctor, you are used to seeing death, and it's something that you're trained to cope with. But I guess in the past couple of months, it has been difficult when you see people's lives being lost and the hurt being caused, and you think that it could have been preventable. As some of you know, I've been quite vocal, particularly at the start of this crisis, on the media about the lack of protective equipment, and critiquing the government's strategy to handling this virus. And I think what's been really interesting, there was one particular interview that got a lot of traction for some reason. And then for that day, I got a lot of people responding to me on Twitter and emailing me, saying that they didn't agree with me, but most commonly in the responses was telling me to F off home. So that was quite like eye-opening, how, you know, exposing how particularly telling. And then I guess what I found particularly upsetting in the past few weeks is when it's become quite clear that Black and ethnic minority people and within the health and care sector have been dying disproportionately. When I've been having these conversations with other doctors, and looking at these conversations being had on doctors groups online, it's been quite upsetting to see the narrative of how this is being explained away. And I think it's exposed that there is a real ignorance there, and we do have problems with racism within the medical community as well. So, you know, I guess on reflection of my experiences over the past couple of months, yes, it's been difficult, and I'm very good at feeling sorry for myself and thinking about all that. But actually, I think if I was to really reflect and think about how this virus has impacted me and my experience compared to the majority of other women working in the health and care sector, you know, actually have had it quite easy. So I thought today I would just tell you sort of the stories of a couple of other women working in the sector to try and show you the sort of the breadth of experiences that have happened over the past couple of months. So I can tell you about the experience of one of the cleaners working in my trust. So across London, actually, many of our cleaning services and our catering services and portering services and transport services, a huge number of services have been outsourced to private sectors, to private companies. And this is problematic for me for many reasons, but it's particularly been, the problems of this have been exposed in the past couple of months because, you know, unlike me, they don't have, well, they get paid a lot less. They don't have that financial support that I have, but also they don't have the rights in the workplace and the job conditions and the job security that I take for granted. So, for example, so in, you know, where I work, actually, most of the cleaners are Black or Asian. Many of them, I say over half, are above the age of 55. So just in that self, that puts them at higher risk from dying from this virus. But I know from a conversation with one woman, she also had underlying health problems, but she couldn't protect herself. She couldn't tell her employer, like I could have done, to say, look, I can't be on the workplace over the next couple of months. I'm putting my life at risk. Because doing that, because of the nature of her contracts, it meant that she would not get paid, and she simply couldn't afford it. And then I can tell you a situation of another woman, also a cleaner, working in a different setting. So she's a woman from India, has been here for about 8 years. And she doesn't have rights to remain here. So she doesn't have many of the rights that many of us take for granted. So this is a woman who she is living in, she's paying over £500 for rent, but she's living in a room with 5 people, and there's about 20 of them living in this property, paying extortionate amounts of rent because, of course, they don't have, because of the right to rent policy, landlords can really expose that and charge extortionate rents for awful conditions. She's working 7 days a week, getting paid less than £3 an hour. Again, it's because her employer knows that she doesn't have the right to work legally in this country. When she has symptoms of coronavirus, she won't go to the doctor because she is too scared that her information is going to get passed on to the Home Office. And when lockdown happened, and when her employer told her that she couldn't come into work because of lockdown procedures, she found herself in a very difficult position because she didn't have access to benefits and welfare support like the rest of us, because she didn't have recourse to public funds. So she found herself in a position where she was having to do work which was putting her health and her life at risk, because the only other option for her was destitution. Now, I'm telling you, I know these stories will be, you know, a lot of people watching this will understand this and know these stories, but I think it's important. Coronavirus has really exposed and has thrived on the vulnerabilities and the inequalities in our society. And I think, you know, I did get cut off your last bit of what Jackie was saying, but I think she did touch on this, how, for example, we know that the financial impact of this virus, women, of course, have been impacted harder, but also, like, we know that from the research being done, that ethnic minority women and other have been hit even harder. We know that they are a bit more likely to be in debt following this virus as well. The care burden, I mean, we're in this feminist space, I don't need to tell you that the care burden, we know, isn't evenly distributed in this country. Of course it is, and the fact that the school closures and social care closures have hit women disproportionately, but again, it is women on low incomes, women in precarious work who would have been hit hardest. And then Jackie also touched on domestic violence. This is something that we've been getting quite a few talks on in the workplace. So domestic violence rates have gone up, you know, quite astonishingly, and it's devastating over the past, since lockdown. But again, we have to think about that women in the LGBT community, ethnic minority women that are low paid, don't have access to resources and won't be able to easily access the support to relieve those abusive relationships. And of course, if you're a migrant woman, there's that additional problem that you can't go to the police if you're trying to escape from a violent relationship, because there is a very real fear that you will then again be passed on, your details being passed on to the Home Office. So I think to finish, I would just like to, I guess, I want us to think about how, I guess, inequalities and discrimination and injustice is entrenched in our economic system, in our laws, in our institution, and of course it has meant that some in our society have not only been more vulnerable to catching the virus, but have been more likely to die from this virus and are more likely to suffer the economic impact from this virus. So I guess it's fundamental, and it's the responsibility of all of us that we address these entrenched injustices, and that is core of how we respond to this virus and how we rebuild the new normal. And finally, I think, right now, these conversations are happening about how we rebuild this country. That narrative is being formed about how we rebuild this country. And I think in light of the past, couple of weeks, when we're thinking about privilege, and I think I've heard some quite problematic, discourse around this, where people, I think we have to think, when we're talking about, if you're white, if you're wealthy, if you're middle class, if you have all those privileges, it's not something to feel guilty about. It's thinking about, or even if you have, privilege, if you are watching this right now, that means you have privilege, right? It means you're in this privileged network, and it means that you have the time and space to have these conversations and think about that. And it's about how you use that privilege, use your influence, use your social power to dismantle these structures of oppression and discrimination, and think about what is your role in rebuilding this system and rebuilding Britain, rebuilding this new normal, so that it's fairer and that it is more just for everyone. So we don't, in this next pandemic, continue to see people in our communities suffer disproportionately, die disproportionately because of racial and economic injustice. I'll finish it there.
Sonia, thank you so much. There was so much that hit me there, but I think one thing you said really early on that really hit me was about the effects on people that work in the health service of seeing people die that wouldn't ordinarily have died or didn't need to die. And I don't think we spend enough time as a society thinking about the mental health of our health workers. There seems to be an assumption that they're somehow immune to feeling of those sort of feelings, and I think that's one of the things I would really like to see given more consideration when we're in or whatever that is. Okay, we'll go on to the next panel member now, who is Nash Nazmi. Nash is a specialist midwife, and she's also a BAME midwife ambassador for NHS England, and she's really interested in working towards health equality. That's one of her big interests. So we're delighted to have her here with us today. So, Nash, I'll let you talk now.
Hi everyone, thank you Fabian for having me and talking about this really important discussion. Now, I initially had something else I was going to say completely, but I think after hearing Jackie and Sonia, it's really important that we kind of talk about what we came into COVID with. So the reason I'm doing my job, and I'm a specialist cultural liaison midwife, what my title initially was BAME lead midwife. And when I started the job role, I said the first thing on the first day was, that's not a title, that is a label. So we're going to think about that. And my amazing trust that I work at said, yes, we are. And you're going to tell us when you're ready, when it's at the bottom of your signature, we'll know what you're going to call yourself. So after a lot of conversation with a lot of different people from different groups, and it was really funny because the comments were, oh, I don't feel like BAME represents me. The M is more like marginalized or minoritized for me personally when I hear that. So if you say that to me, I will instantly be backed up or against, feeling completely against the tide. So the cultural liaison midwife title came because we want to make it inclusive and talk about how everyone has a culture and it's okay, and what are those cultures and what gaps do we have that we need to build on. Now, the foundation of my job was the Embrace report that came out a few years ago, and it's been highlighted again last year, that Black women are 5 times more likely to have higher mortality rates than white British women. Women of mixed heritage are 3 times more likely, and Asian women are 2 times more likely to have higher mortality rates. So if we put that down to the most basic lesson, that is, they are more likely to die in comparison to a white British woman. That doesn't matter on education level. You know, it's not about women who have immigrated. It doesn't matter if you're British, Asian, or someone who's immigrated. Now, for me personally, I'm an immigrant. I was 4 years old when I came to this country. So I'm personally affected by that, and often hear stories from my wider family about how they feel about that statistic. The sad reality is that's been out there since about 2017, and a lot of focus has been on it and conversation has been started, but that's as far as we've gotten. Conversations. And when I started this role, I was given the opportunity to look further, and then COVID hit. And I started slap bang in the middle of COVID. So if I could, I'd be out in the communities talking to the women and asking them what their experiences are of maternity services. Where are the barriers that exist that we are unaware of? We know there's socioeconomic disparity. We know there's other problems. We've always known that, and there's always almost been used as an excuse. We often, when we talk about these communities, we often say that they are hard to reach communities, but after numerous conversations, I can say that they're actually an easy to ignore community. When we approach these communities, we need to get to them and talk to them and build a relationship before we can expect anything back from them, because they have been in a cycle that's perpetually been affecting them in the long term. And then COVID happened, and UCOS data has recently come out to say that 56% of the women that are likely to be hospitalized with COVID were BAME. So it's that cycle that Sonia's mentioned, that Jackie's mentioned. It's just been highlighted again that these are the communities that need the most attention, but very little attention has happened from where we have been in the past. So my job has started to look at that from that point of view, but going into midwifery and being on the workforce being on the shop floor before I finished, I saw amazing women. Now, midwifery is a profession that is mostly dominated by women. We would love men to join, so if there's any men out there thinking about a job change, please come. We're a very inclusive profession, and we would love it if you could join us. But it is predominantly women, and when I've seen these women roll up their sleeves and just put a smile on, and I have never felt the morale like it has been right now in midwifery. There was such a coming together, and things were changing every 2 minutes, guidelines, how we're putting PPE on, how we're not putting, what PPE it's going to be, where we're going to be, what rooms, what wards, etc., etc. The change was constant, and it was every 2 minutes, and the way everyone came together was so vital, and it shows that we are a strong community. What then happened was they got tired, and then our amazing professional midwifery advocates came to support staff, because staff well-being and anxiety started to come out, and that was something that was new. And being able to support staff is something that I think has come out massively in the NHS. The amount of talk about staff well-being, I've never seen the amount of conscious discussions happening on the work floor about, first of all, people supporting each other and people advising each other. There's been talks about meditation, there's been group hypnotherapy, there's been online Zoom hypnotherapy sessions. So much amazing conversation has started because of COVID, unfortunately, but it started. The reality for the pregnant women is that all the things we were doing in the way we were doing has changed. Pregnant women and pregnant people currently are not able to have the amount of visitors that they normally would. We've consciously tried as much as we can to support women, and midwives are going out of their way to be extra smiley because those masks cover all of hair, so you have to like smile even harder to make the mask raise so that someone can see that you're smiling. There's been other barriers in the sense that ladies that have problems with hearing and that often use sign language, they are not being able to see your lips, so you're having to work around that and trying to use services that you may not have used earlier. But the fact that we've been able to make things happen so quickly which we weren't able to make happen earlier just shows that when we put our heart and soul into it, we can make things happen. Unfortunately, the NHS has some kind of amazing history, and it's really long, but when we want to make change, it takes longer than we want. But now we're at a stage where everything's happened so quickly, it shows that we just need, this is like Sonia said quite clearly, this is the time, and this is how we need to decide where we want to go from here, and the opportunities are massive. And thank you so much.
Kelly, you're muted. But thank you very much. Yes, you can hear. That's lovely. So thanks very much to the Fabian women for inviting me along. It's been really fascinating listening to the three previous speakers, and I'm really appreciative actually to be able to hear them. And I think probably my role as the last speaker is to try and draw together some of the themes that have been articulated so very, very clearly by the previous speakers. And I guess that what I really should start off with saying, because I'm a clinical academic, is just emphasizing some of the, with a few objective numbers, some of the really powerful things that you've heard already this evening. So first of all, let me acknowledge that men are more likely to die from COVID-19. However, having said that, let me put that to one side and say that, of course, we're here to discuss the impact on women. And I think that one very helpful way of considering this in totality is to consider COVID-19 as a stressor, which has exposed weaknesses in our healthcare system, in our economy, and in our societal systems. And what it has done, as has been very clearly said, is it's magnified the disadvantage which is already experienced by women and children around the world. So I want to make 3 points first off. First of all, about the immediate impacts on women. And this is to say that inequalities will widen, and we're seeing this already, and poor women will get poorer. What are the underpinning reasons for that? Well, about 70% of the global healthcare workforce is made up of women. In the UK, the figure is 77% of frontline healthcare workers are women. And of course, the majority of low-paid healthcare workers are also women, about 70% again. And as has been said previously, it is women who have more unpaid caring responsibilities than men as well. It's been estimated that on average, they do about 60% more unpaid care work than men do. And then the final really, really painful statistic is that women are more likely to be in poverty. There are about 3 million people in high-risk healthcare jobs, high-risk jobs in the UK. And again, about 70% of those, just over 70% of those are women. And of the 1 million of these vital healthcare workers who are below the poverty line, about 98% are women. So I repeat, COVID-19 is going to widen inequalities. Women are going to suffer even more than they have done historically. The second point, which again, Sonia made very clearly, is about intersectionality, because we know that over half of pregnant women admitted to hospital with coronavirus come from a Black or Asian minority ethnic background. BAME women are 4 times more likely to be hospitalized. But the third point is one that hasn't been made before, and I'd like to really emphasize, and that is that maternal health and infant health influences population health and socioeconomic resilience, both in the short term and in the long term. We've talked about the short-term impacts, but I just want to mention the long-term impacts, because these, I think, need to be recognized more widely. And we know from previous socioeconomic shocks on a global scale, from the historical famines going back a century, to more recent events like the 2008 global financial crisis, that all of these have very adverse effects on pregnancy outcomes. There have been higher rates of preterm delivery documented, higher rates of growth-restricted babies, in other words, babies who haven't grown as well in the womb, and preterm babies and growth-restricted babies are much more likely to grow up to have an increased risk of chronic non-communicable diseases like diabetes and high blood pressure when they grow up. So the impacts of these disadvantages on women's health and on women's well-being have got very, very long-term impacts, which not only affect people's health and well-being, but also inevitably, therefore, impact the economy and therefore impact on all of us. And so globally, the unemployment, the reduced household incomes, the stress, the violence, the confinement, the food insecurity associated with this response to COVID-19 will have a disproportionate effect on mothers and babies, and even more disproportionate amongst those who are already disadvantaged. And these adverse longer-term impacts could have been mitigated had women not been so vulnerable at the outset. So there were two issues that have been raised by the audience, by Lisa and by Helen, about health systems and about the economic things, the case that we should be making for the future. And I'd like to end really with what I hope will be a positive note, because although the immediate consequences of COVID-19 have been tragic, and we've yet to see the full tragedy unfold, if there is willingness, this is a natural experiment from which we can learn and which we should use to drive future improvements. We can use it to drive future improvements in systems, in healthcare systems, in the policies and in the ideological thinking that underpin these systems. And I also want to leave you with a thought that there has never ever been a time in human history when we faced a pandemic, but we've been able to understand it and combat it in the way that we can with COVID-19. And just one example is to say that to be able to sequence the viral genome, to identify the molecular targets, to start to produce vaccines within a year is absolutely unparalleled in human history. But of course, we should also ask ourselves the question, does political and economic thinking match the progress made in science? And the audience will have their own views, my colleagues will have their own views, but sadly, my view is that the answer is sadly not. We still don't have a gender equal economy. And unfortunately, how can I put this? Many countries are still reaping the consequences of their choice at the ballot box. And I would say that economists are still thinking, and politicians, and indeed the public, are still thinking in terms of the old failed model of economy, which is modeled on growth and profit rather than sustainability and well-being. So I think the pandemic should be viewed as a wake-up call, which is offering us opportunities to rethink the whole of the human condition, so that we should be promoting population health and resilience by recognizing the importance of women's health and infant health in order to reap the benefits in the long term, to create a life course agenda for health. I also think we should be creating a gender equal economy that doesn't favor a male workforce and really favors sustainability and places sustainability in premier position over growth and profit. But in order to do this, we need political leadership, we need societal maturity, and I think it needs us, women, the public, the women within the public, to be very, very proactive in advocating for change. And my final point I would say is that we, I think, should recognize that we do ourselves damage when we accept the premise that we should continue to carry the major responsibility for caring for children, for the home, for elderly parents. These are shared family issues, and we should discuss them and promulgate them and advocate for change on the basis of them being shared family issues and shared societal issues. So I will stop there, Kelly, because I hope there'll be time for questions. But again, thank you very much indeed for inviting me to be part of this. And I hope I've raised a few thoughts for people to think on.
Lovely, thank you. Hopefully my internet has calmed itself down now and is working better and everyone can hear me. So we're going to move to questions now. We've got some great questions and quite a lot of them run along a similar theme. So I'm going to start with a question from Helen. She says it's good and awful to hear stories from women and especially contracted workers. Since the pandemic has started, the government has contracted more and more services to the private sector, including the test and trace. How can we highlight and counteract that? So if we can go, Sonia, can we go to you on that one first, please? Sonia, you're on mute.
I couldn't hear the question, Kelly.
Okay. So, sorry, my screen is up. Basically, the question was about how we can counteract and stop the contracting out of services such as trade and trace, but other services that are currently being contracted out as we during the pandemic. Yeah.
How do we stop services being contracted out to the private sector?
Mm-hmm.
Yeah.
Yeah.
Given and it's happening. Yes.
Okay. I think my internet's really bad because I can't hear very well at all. But about how do we stop services being contracted out? So I guess there's two things here. How there are already services that have been contracted out to the private sector, and I think there are things that we can do right now. So in the hospital where my sister works, she works in Homerton Hospital, and their cleaners right now are having a dispute with their employer. I think I can't remember what private company it is, but they're trying to extend their contract for another 5 years, and they don't have sick pay guarantee in that contract. So I think there are people that are already employed in these, who are already under these private sector employments. We can help them to, I think, unionize, and it helps them so they can work together collectively to try and get better rights and working conditions. So that's what we can do right now. I think we should be trying to, I think there's also, because I tried, in the last election, we were trying to talk about this quite a lot. And I think it's actually quite difficult for a lot of the public and actually a lot of people working in the NHS to understand that this is happening, because let's say if you go into my hospital, you won't see that the cleaners are have been outsourced to a private sector company, because they look like that they are in the uniform, they are working in our wards. So I think there's a lot of actually ignorance there about what's happening. So I think just raising awareness about this is also really important. But yeah, I think also we need to mention, like, right now during this coronavirus pandemic, there are things that are being outsourced to the private sector which shouldn't be. So the track and trace systems, I think there's been quite good coverage about this in the media. Why was it, I think it's Serco that it was outsourced to? Why it's ridiculous that it happened. Why weren't we using existing public health systems? Why weren't we using general practices to do this public health work and this contact tracing work? So I think it's about raising awareness is one thing. I think people that are employees, workers that are already have already had their jobs outsourced. I think about helping them unionize to collectively fight for better rights and conditions is also really important. And then also going forward, really making that case for bringing our NHS back in house. There has been push from this in legislation. The Labour Party did have this in their manifesto in the last election. So I think it's about pushing for that as well, legislation wise, to renationalise our NHS as well. I don't know if you can hear me at all, but oh, you can again.
Can everyone hear me now? Okay, Jen, answer the question.
Okay, hello. Can you all hear me? I'm just going to jump in and ask the question because I think my internet might be a little bit better. So the next question for the panel we've got from Lisa. She'd like to ask, how do the panel think we can start to reframe the narrative that we seem to have nationally? We hear very little discussion around the economic case for public health, especially in a time of crisis. The government seems to have allowed Public Health England and the NHS to take the blame for a lack of robust pandemic plan. without any acknowledgement that it is economic reality which leads to poor public health. How do we make that complex argument more accessible? So I don't know, Jackie, you want to take that one? Or?
Okay, I mean, this is something, of course, that I mean, the economic challenge for us, I think, manifests in the health service in terms of the sort of inequalities that quite a few of us have been talking about. And in Birmingham, we quite often talk about the fact that you can travel, if you travel 7 stops on a train, you will, on the train lines that go through Birmingham, you will go from one part of the city to another part of the city where there is a 10-year discrepancy in the age at which people are dying. So this is a reality for people now, and that's largely down to economic discrepancies and inequalities of economic wealth and income, which lead through to health inequalities. So one, that makes it real. Then I think we need to find ways in which we can make that more of a reality in the way in which we prioritise public health, in the way in which we see the system much more as a system. So, you know, I'm responsible for a very large acute tertiary trust. But what I very much know is that a vast majority of what we're responsible for treating could have been prevented had we had a more effective way of tackling those inequalities before people even get anywhere near the hospital. Not all of it, and we will always need big tertiary hospitals like mine, but it's not enough to wait until the results of those inequalities come into our hospitals before we tackle them. And health inequalities are something which up to this point, and certainly within the current political environment, had very much, if you like, gone out of political fashion. And as others have said, if this crisis has shown us anything, it's that if you come into a crisis with health inequalities, people will suffer disproportionately, and more seriously, they'll be exacerbated as we go out at the other end. And hopefully that reinvigorates the push to help to tackle those as we go forward.
Thanks very much, Jackie. We've got one more question from Sue, and she'd like to know, how can we place values rather than balance sheets at the heart of policy making? So I'm not sure who wants to take this. Any volunteers?
So shall I take this one?
Yep, great, thank you.
And I guess it speaks to the previous questions too, because you know, there is a great intersectionality about the points that have been made. If we're going to put values at the heart of what we want to do, it's a question of what do we value, and it's a question of do we recognise the value of, for example, health and well-being. And unfortunately, the question about the involvement of the private sector in healthcare has absolutely made the point that healthcare has not been treated in this country with the value that it requires. It's been treated as a commodity to be bought and sold, rather than recognizing it as an absolutely essential necessity for a sound society and a healthy society, and therefore inevitably a wealthy society. Because if your workforce, if your adult population is crippled with, for example, this seemingly inexorable rise of chronic non-communicable diseases, they are not going to be an effective workforce, and inevitably there's going to be an impact on the economy. So, and this is why I made the points about we need a new economic model that is not built upon judging success by the amount of growth and the amount of profit that you make, but is modelled on something completely different, which is this a healthy society? Is there well-being in our society? And I would like to issue a challenge to all those economists out there because there is a Nobel Prize for someone who can actually change the thinking around how we actually model our societies. There's also a great need to pick up on previous points to reverse some of the inequities that were introduced with the 2012 Health and Social Care Act, which actually did commodify our health service, and go back to thinking about what is the value of the health service. It's not turnover, it's not profit for private companies, but it is the health and well-being of the nation. And the third strand of that is prevention, because we should focus far more on prevention. And yet, as you will all know, the Public Health England budget, the prevention and public health budgets have been severely axed in recent years, so that we have got these interrelating factors which are coming together to produce an impact that is extremely tragic and extremely sad, and there's repercussions for this for many, many years to come.
Can you hear me? Lovely. Thank you so much for stepping in there, Jen. So the next question is for, in practical terms, how can we campaign for improved pay and conditions for nurses or healthcare workers? Renee, you're on mute.
I'm just going to repeat that question because I'm not sure we could all hear you. So that was, in practical terms, how can we campaign for improved pay and conditions for nurses and all healthcare workers post-COVID-19?
Wow, that's a big one, isn't it? If I could answer that, I would already be working towards it. What I would like is, first of all, I always talk about having the conversation first. Whatever I try to do, I first try to have a conversation with the people that are involved, because we don't know what their realities are and what they're facing on the shop floor before we start campaigning for anything. How can you campaign for anything without having their voices as part of that conversation and part of that campaign? So if you would like to ask that, I'm not nurse trained, so I'm definitely not the right person to answer that. But as a midwife, if people are campaigning for this, come and speak to us, come and speak to nurses and see, first of all, what it is that affects us. And then we'll take it from there. But a lot of things need to be a conversation that needs to start with the people we're doing it, rather than having a situation where you end up with a title like BAME and someone changing that later down the line because they don't like it, because they never got asked in the first place.
Sonia was right before. You want a trade union and unionise those sectors that are ununionised at the moment, particularly in social care.
Thanks. Okay, so we've got one more question left. I think we've got just about enough time before we can do our closing remarks. So we've got one from Sela, which I'll just put out to the whole panel. Why do we think that there are so many BME workers dying during this crisis?
Should I go?
Yeah, thanks, Sonia.
So this is a big question. I think, generally, so it's not just BME workers, but we know that Black and ethnic minorities are dying disproportionately from the virus, and there's lots of factors here that are at play. I think it does, to a large extent, mirror I think the first thing that we should say is that prior to coronavirus, these, and as others have mentioned, these health inequalities between racialised groups already existed. So as was discussed, we know that Black women were dying at much increased rates in pregnancy than white women. We know in the mental health system, we know that Black men are 4 times more likely to be sectioned under the Mental Health Act than a white man. So, across the sector, we see these disparities. We see it in cancer care as well. And, I think, to some extent, these health disparities between racialised groups mirror the social and the economic disparities that we see between racialised groups. So as Jackie mentioned, where she works, where you live, to a large extent will determine your life expectancy, and that's because your social world and your economic world and all those exposures have a massive impact on your health. and your ability to live a healthy life. I think if we're looking particularly within the health and care sector, I think there is particular issues that we need to look at. So we know that, prior to this virus, we know that, if I talk about my own profession, that Black and ethnic minority doctors were not just more likely to be complained about, but felt much more less able to speak out about issues about bullying or workplace safety. And we know over the past couple of months, and I know this anecdotally, but also that there's been surveys done that Black and ethnic minority doctors and nurses have found it more difficult to speak out about lack of protective equipment. Many have felt pressured to continue working in unsafe settings. And there's also, and this has now been shown in some trusts, that Black and ethnic minority, particularly nurses, are being redeployed to be put into high-risk situations at greater numbers than their white counterparts. So I think that there's issues there within the workplace, within the NHS, that we've actually known about for quite a long time, issues around institutional racism that hasn't been adequately addressed. And then, of course, as we mentioned earlier, there's all the other factors, and particularly this problem in the care sector, that when you don't have the adequate rights in the workplace, when you don't have job security, when you don't have income security, it's much more difficult to isolate if you're at risk for those various reasons. And then I think, people have been talking about these biological factors of why ethnic minorities are at greater risk. And it is true that ethnic minorities in this country are more likely to have heart disease, more likely to have hypertension, more likely to have diabetes. Again, a lot of these diseases are impacted by your risk of getting them, and also how well they are managed, how well they're looked after is impacted by your social and economic circumstances. And as Professor Modi mentioned, also your mother's health and your mother's conditions, and how you're and from birth, all of these conditions will impact your risk of having illnesses, and then increasing your risk of dying from the virus. So sorry, it's a very long answer. There are lots of factors that intersect here, and so there isn't one answer. But I think having an independent public inquiry into this, which a lot of ethnic minority groups have been calling for, I think is really important, and the first step to start to understand and acknowledge these disparities. And I think we do need to take some real steps to try and understand why these disparities are happening and what needs to be done to address them.
Okay, I'm hoping everyone can hear me now. So I just want to say thank you to Jen for all she's done stepping in with my internet disaster tonight. And thank you to our amazing panelists. It's been so wonderful to have you all with us tonight. So much for us all to think about, so much for us all to learn. I think it's so great to have experienced female voices that can show us so many more perspectives on the health sector as a whole. So thank you very much. For anyone watching, please do think about joining the Fabians and finding out more about Fabian Women's Network, which is an amazing organisation. So we'll just say thank you and good night for everyone now.
Bye-bye.
Thank you.
Thanks a lot, everyone. Bye-bye.